So we're going to be doing the lower leg by Stephanie and Neha.
So our objectives, the first, be able to identify the compartments of the lower limb, be proficient in identification of the major musculature of the lower leg, so like the origins and the insertions, as well as the actions and innervations, be able to identify the major nerves and vessels of the lower leg, and then become proficient in clinical application of the lower leg anatomy in regards to injury and anatomy. Lower leg musculature. So there's 4 compartments that are encasing the muscles within the lower leg. The first compartment is the anterior. It contains the extensor digitorum longus, the extensor hallucis longus, as well as the tibialis anterior. The lateral compartment contains the peroneus longus, brevis, as well as the tertius. The superficial posterior, so that's the gastroc, plantaris, and soleus muscles. And then the deep posterior is the posterior tibialis, the flexor hallucis longus, the flexor digitorum longus, and the popliteus. And there's a picture where you can see the different musculature and where they lie. So breaking it down by compartments, the anterior compartment, the extensor digitorum longus, so the origin is on the lateral condyle of the tibia, the proximal and anterior shaft of the fibula, and the interosseous membrane. It inserts on the middle and distal phalanges of the 2nd through 5th toes, and you can see that there in the picture. The extensor hallucis longus originates in the middle and anterior surfaces of the fibula and interosseous membrane. It inserts on the distal phalanx of the 1st toe, and then the anterior tib, which is green in the picture, originates on the lateral condyle of the tibia, the proximal and lateral surface of the tibia, and the interosseous membrane, and it inserts on the medial cuneiform and the base of the 1st metatarsal. So the lateral compartment, the first one we're going to talk about is peroneus longus. It originates on the head of the fibula and the proximal 2/3 of the lateral fibula, inserts on the base of the 1st metatarsal and the medial cuneiform. Then peroneus brevis, you can see in the picture as well. It originates on the distal 2/3 of the lateral fibula and inserts on the tuberosity of the 5th metatarsal. And then the third is the peroneus tertius that originates on the 3rd quarter of the anterior shaft of the fibula and inserts on the shaft and base of the 5th metatarsal. So you can see in the picture with the foot, this one with the foot pointing that direction, you can see how we were able on our bodies to find them at their tendinous insertions, but as it went more and more towards the origin, this kind of got a little bit messy to find. So that was probably the most complicated muscle or group of muscles, I would say, that we had in our dissection, but we were able to find most of those and differentiate them. So the superficial posterior, so those are the gastroc. It originates on the condyles of the femur and the posterior surfaces of it. Inserts on the calcaneus via the calcaneal tendon or the Achilles tendon. That was the easiest one to find. Next was plantaris. It originates on the lateral supracondylar line of the femur and inserts on the calcaneus via the calcaneal tendon or the Achilles tendon. And then soleus, so it originates on the soleal line and inserts on the calcaneus via the calcaneal or Achilles tendon as well. And you can see those pictures. You can see the picture of it and determine which ones are which by the color on the image. And then lastly, you have the deep posterior compartment. So your posterior tibialis originates on the proximal posterior shafts of the tibia and fibula and the interosseous membrane, and all 5 tarsal bones are where it inserts in the bases of the 2nd through the 4th metatarsals. You have the flexor hallucis longus. This originates on the middle half of the posterior fibula, inserts on the distal phalanx of the 1st toe, and then the flexor digitorum longus originates on the middle posterior surface of the tibia and inserts on the distal phalanges of the 2nd through 5th toes. And then lastly, the popliteus. It originates on the lateral condyle of the femur and inserts on the proximal and posterior aspect of the tibia. And you can see the different colors of those muscles as well in the image.
Okay, so now I'm going to be talking about lower leg intervention. So again, we're going to go by the compartments that Steph had mentioned earlier. So in the first one, you have the anterior compartment, and that's where you have the deep peroneal nerve. So of course, that begins at the bifurcation of the common peroneal nerve between the fibula and the upper part of the peroneus longus. And then that's deep to the extensor digitorum longus. And then in the lateral compartment, you have the superficial peroneal nerve that innervates the peroneus longus and peroneus brevis muscles. Third one, in the superficial posterior department, you're going to have the sural nerve, and that basically consists of the fusion between the medial and the lateral sural cutaneous nerves, which of course then become the sural nerve or form it. And then the deep posterior compartment, you have the tibial nerve, and that's a branch of the sciatic nerve and passes through the popliteal fossa to pass below the arch of the soleus. So we did find quite a few tibial nerves, at least I think 3 of the bodies, in terms of the deep peroneal nerve and the sural nerve. We may have found 1 or 2 sural nerves, but a lot of times it was hard to decipher and just figure out the nerves in some of the bodies. And then in terms of the arterial supply, in the anterior compartment, you have the anterior tibial artery. It carries the blood to the anterior compartment of the leg and the dorsal surface of the foot. Alongside that, you do have the veins as well. And then we didn't find anything in the lateral and superficial posterior compartments. In the deep posterior compartment, you do have the posterior tibial artery, and that gives rise to the medial planar artery and the lateral planar artery as well. And of course, at the end, gives rise to the fibular artery. And so we did find the fibular artery. I'm pretty sure we found the anterior tibial artery as well. Again, a lot of times it was hard to decipher between the veins and the arteries in some of the bodies, but we did find quite a few. And then this is just a picture of, this side just shows all the nerves from the beginning or the top of the leg down, and then again all the arteries as well. In terms of clinical application, there's quite a few things you're going to find in the lower leg that you may see when you have patients coming into the clinic as future PTs. So the first one, compartment syndrome. This is an exercise-induced pain, but it is relieved by rest. It usually occurs from repetitive loading exercises or activities. A lot of times you're going to see this in athletes. It usually occurs with excessive pressure that builds up in the muscle space in the body. So it's really important to educate your patients on rest and why this is happening to them. And Achilles tendonitis, it's an overuse injury of the Achilles tendon. Pretty common. It's usually going to occur in runners, especially cross-country runners, because they're going to, whether they increase their duration or intensity of their runs. And you can actually find this in middle-aged people that come into the clinic, especially if they play sports in the weekend, so not like all the time. And so they might feel a pull or they might feel pain in that Achilles tendon and come in and not understand why. Because it usually begins as a mild ache in the back of the leg or above the heel after the activity. So again, it's just all about that rest and icing to reduce that inflammation and educating your patient. And then you have shin splints, of course, is super common, and that is the inflammation of muscles, tendons, and bone tissue around the tibia. Another exercise-related problem usually occurs in the inner board of the tibia where the muscles attach to the bone. And, a lot of times you can, again, tell your patients that it's not super difficult to reduce your pain for shin splints. It's all about rest, icing, and stretching, which definitely helps. And not to overdo exercise, like the exercise routine that they usually do. And then high ankle sprain. So a high ankle sprain occurs when there's a tearing and damage to the high ankle ligaments. These injuries are much less common than traditional ankle sprain. So you're not going to see it as often. Usually occur from rotational injuries, kind of like ankle fractures. So usually from external rotation. Patients who have a high ankle ligament tear usually will have pain just above the level of the ankle. And then lastly, you have the peroneal rupture, and that is a result of an inversion ankle sprain. During an ankle sprain, the peroneal tendons pull up against the outside of the ankle to restrain the rolling motion of the ankle. And so peroneal tendon tears are found equally, again, with both genders, and the onset of tears are during adult ages 25 to 60 years of age. And then now we have questions.
So question number 1, what compartment is most affected by compartment syndrome of the lower leg in some athletes? A, is it deep posterior? B, is it lateral? C, is it superficial posterior? Or D, is it anterior? And the answer for that one is D, which is anterior. Number 2, what nerve innervates the gastroc? A, is it deep peroneal nerve? B, is it tibial nerve? C, is it superficial peroneal nerve? Or D, is it the sural nerve? And the correct answer to that is B, which is the tibial nerve. Number 3, what is the flexor retinaculum? A, is it a band that covers the tendons of the posterior compartment musculature? B, is it a ligament that connects the gastroc to the calcaneus? C, is it a thin fibrous tissue that acts as a pulley for tendons of the lower leg as they enter the foot? Or is it D, a fiber that encases the entire tibial nerve? And the answer to that is C.
Then you have what immediate nerve does a tibial nerve come from? Is it A, femoral nerve, B, sciatic nerve, C, obturator nerve, or D, quada equina? And the answer is B, sciatic nerve. The last question is, this is induced from an exercise-related pain, but it is relieved at rest. Is it A, high ankle sprain, B, Achilles tendonitis, C, peroneal rupture, or D, compartment syndrome? And the answer is D, compartment syndrome. And that's all we have.